I request first speaker, Dr. Jyoti Prakash Vyas. He will be presenting on deciphering OCT in AMD and PCV.
Good morning, all. Thank you, Dr. Anubhav, for the invite to the IC. I'll be talking about OCT in AMD and PCV. So this is the normal looking macula on an OCT. You can see the well-defined layers, and we'll be trying to explain what to look for and interpret in a case of AMD as well as PCV. This is an animation just to show. Light. If you can see, I don't know. It's an animation showing the macula and the outer retinal layers and the underlying choroidal vasculature. So the retina normally receives nutrition by diffusion from the choroidal layers, and the waste products from the RPE are pumped up into the choroidal vasculature, which drains off into the venous system. In due course of time, as the retina ages, the RP cells get a bit older. They tend to their functionality reduces, and they tend to accumulate a lot of lipofuscin into the space, and which leads to reduced oxygenation of the RP cells and accumulation of drusenioid material in the course of events. This is the histopathological structure of the RP cell and the Brooks membrane, where the early basal lamellar deposits are seen, and the basal linear deposits are seen exterior to the basement membrane and between the Brooks membrane, which is said to be the precursor of the drusenoid material. Development of a subfoveal CMVM, in contrast to just the deposition of lipofuscin, begins as a growth due to the relative hypoxia of that particular layer, leads to a development of new vascular fronts below the Brooks membrane. In due course of time, there's a breach which develops into the Brooks membrane. The vascular structure comes to lie in the sub RPE space. Then exudation begins, breaches occur, microrips occur in the RPE, the fluid travels across into the sub-RPE, subretinal space, and subsequently neovascularization follows. So now with this backdrop, now if we start looking at cases of AMD, the first thing which we look at is the drusen, as I had put forward. Now these are seen as little bumps in the outer retinal layers, and they can be seen either as a singular deposit, multiple lesions, and as the disease progresses, they can be seen as a confluent lesion when clinically it is seen as a soft drusen. When they clump together, they are labeled as drusenoid PED, and these are said to be precursors of wet AMD. When you see a drusenoid PED, the chances of progression are slightly higher than isolated drusens. Now, PEDs, that is pigment epithelial detachment, can be of various types. It can be serous, fibrovascular, or hemorrhagic, which can be seen in the photographs in the front. The serous has a hyporeflective space, empty space without any backscattering under the RPE. The fibrovascular element thus shows some element of backscattering just beneath the tip of the pigment epithelial detachment, which highlights the area where the fibrovascular element is there. And in the hemorrhagic, you can only see significant backshadowing because of the thick blood present there. This is a type 1 macular neovascularization, as it is nowadays called. Earlier it used to be called as choroidal neovascularization, now it is labeled as macular neovascularization. Now in this, if you just look at the individual elements, this arrow shows the area of intraretinal fluid. This is the subretinal fluid. This happens to be the subretinal hyperreflective material. This is the area of backscattering from the fibrovascular PED, and this happens to be the the thinned out choroid, the compacted choroid, as opposed to a pachychoroid, which is seen in PCV and its variants. Now, this is one case in which we saw the fundus of a patient who has drusens in the left eye, in both the eyes, and the right eye also shows a focal lesion, hemorrhagic lesion. So this patient had been followed up over a period of 5 years. So if you look at the autofluorescence in the right eye, in the right and the left eyes, 5 years apart, there's not much of a change other than the increase in hypoautofluorescence in the right eye, and the multiple punctate lesions which are seen scattered all around are typically known as reticular pseudodruseness. Now, this is the scan which was taken in 2016, which shows only small drusenoid deposits, and shift over to 5 years, you see extensive large fibrovascular PED with serous macular detachment, with intraretinal fluid, hyperreflective dots, suggestive of type 3 macular neovascularization, or as it is known as RAP. This is another patient which has a type 2 or a subretinal or the classic macular neovascularization, in which you can see the 9 layers of the neurosensory retina being lifted up by a serous macular detachment and the choroidal neovascular membrane sitting there. This is a disciform scar, which is the end stage of any form of ARMD, and it is usually associated by what is known as ORT, or the outer retinal tubulations. These are said to be an abortive effect of the residual photoreceptors, which tend to coil up upon itself, leading to a structure which is hyperreflective in the periphery, and the central core is hyperreflective. In cases of PCV, if we look at it, PCV, usually ICG happens to be the investigation of choice, but there are certain markers and certain structures which can be seen on an OCT and can give you a clue as to what we are dealing with. Now, what has been labeled as the peaked PED by the sheer appearance of it, you can think about PCV. The other lesion being the thumb-shaped PED. Then there is something called as the notched PED, which is nothing more than a PED with an adjacent area of the polyp at the slope of the PED. And if you look at the red arrow, you can see the lumen of the polyp within that area. Then comes the DLS, or the double layer sign, which is also labeled as SIRE by Bailey Freund in 2016. This is also known as the shallow irregular RPE elevation. So these findings put together may hint towards occurrence of a PCV. Thank you.
Thank you, Dr. Jyoti. Anyone has any points, anything to ask, any question to ask? So we put this IC just to see. Nowadays, OCT is the still a very important investigation, and the basic investigation which every hospital, every institute, even basic clinics have. So understanding of OCT is important. So in this, we have to differentiate whether it is intraretinal or it is retinochoroidal difference pathology. Retinal means it's mainly edema part, retinal edema, which can be because of diabetic or other parts. But retinochoroidal means it is basically involving choroidal area, also with retina, and mostly seen in wet AMD cases. So how to differentiate it? This talk is very important in this. PED, which is a significance of wet AMD, has to be associated with intraretinal changes like intraretinal fluid and subretinal fluid. So this is point to be, just want to highlight this. The second talk is basically on by Dr. Sailesh Kumar. He'll be presenting on poor prognostic markers, OCT based biomarkers in DME and AMD.